Good afternoon and welcome to Bariatric Friday. My name is Kemal Erkan. I'm the chairman of American Surgery Center. This is our weekly bariatric update where we go through a lot of different topics involved bariatric surgery, pre and post surgery. And for those who are already in the program or already completed the program, or maybe thinking of getting into surgery. So this is a resource for those individuals who are looking to find the most effective solution for morbid obesity. So I have Dr. Irgau with me. And Dr. Irgau, how are you doing?
I'm doing great, Kemal. It's again great to be back on another session of Bariatric Friday. The feedback I get from our patients is always great. They appreciate the variety of topics that we cover. They appreciate the casual nature of our presentation in that it is more conversational than lecture type. And many patients tell me they have no questions before surgery because they watched many of the sessions we have on Bariatric Friday.
That's great to hear. And the last session that we did was part of the, it was the first time we tried where I was doing the mock patient for a nutrition visit with one of our dietitians. And I think that we'll have another session because we covered some and we are going to cover some more. Our goal is to provide more resources out there. So then every time there is a need, they can actually turn one of these videos on and then maybe watch it and rewatch it again to get the information that they need. We try to keep these shorter than regular lectures, as you mentioned. But we also have our regular lectures twice a month on Tuesdays at 6 p.m. You can get the information on our website as well as on our Facebook and other social media sites. So we are going to discuss the bariatric surgery types, what's right, what's not, which one is the best. And patients may come to our offices with their opinions, and we'll demonstrate how we actually make those decisions. And Dr. Irgau is going to help us with that process.
Absolutely, absolutely. So essentially, as we've said many times, bariatric surgery is now established as the most effective treatment we have for morbid obesity. Morbid obesity defined as obesity which is out of control, with a person's weight being about 100 pounds or more above their ideal body weight. So if a person's ideal or healthy weight is supposed to be 150 pounds, and yet over the years they continue to gain weight and now they are 250 pounds, that is actually the definition of morbid obesity. And of course, we have another way of quantifying that when we talk about BMI or body mass index. And the number that we look into is a body mass index of 40. Although sometimes if a person has developed certain illnesses related to obesity, like type 2 diabetes, high blood pressure, or sleep apnea, even a body mass index as low as 35 could make them qualify for bariatric surgery. So the issue is what type of bariatric surgery? Of course, the best bariatric procedure will be the one that is appropriate for that particular patient, right? And where patients are different, and we have to apply the individual's particular history, comfort level, risk tolerance, and all those things have to be brought into consideration when we make a decision about which is the best bariatric procedure. And needless to say, this is a decision that is made in a collaborative fashion between the bariatric surgeon and the patient as well. Of course, we can look at bariatric procedure in terms of their invasiveness, right? Kemal, like we've said before, we talk about the least invasive procedure that we offer, like the gastric balloon, for instance, and then we can talk about the more invasive procedure like the duodenal switch. And then there are other procedures in between, like the gastric band, the gastric sleeve, which is by far the most common and popular procedure that we do. And of course, the fairly well-established procedure from a long time ago, which is the gastric bypass. I would like to start with the most common procedure, if I may, Kemal, which is the gastric sleeve. And the first myth I want to throw away is that the gastric sleeve is not the placement of a device, right? Because the name of the procedure itself kind of makes people think as if we're going to put a sleeve around the stomach. Well, it's not. What we do with the gastric sleeve is actually division of the stomach. So the stomach that was large like a watermelon now is divided with a portion of the stomach removed, and it looks more like a banana now. That's really the essence of this sleeve gastrectomy.
If you remember, I used to think that it was, and earlier on, it was something that we were taking that extra skin, extra stomach that we were cutting and then wrapping around the other. So apparently that was not the case. So
absolutely.
If we have to come up with a new name, it would be different, I guess. But it's mainly taking that big portion that's no longer needed and making the stomach a lot smaller than what it is. But we still have a stomach, right?
Absolutely. So it shows you that the stomach as an organ plays a very important role in our energy balance, in determining how much fat we will accumulate and therefore excess weight over the years, right? Because it determines how much food we eat. And it's not just a question of the stomach being large and accommodating for us to eat when we feel like eating, Kemal. It's more than that. The stomach actually does have a critical role in communicating with our brain about levels of hunger and levels of fullness. And that particular portion of the stomach that we actually remove when we do the gastric sleeve is the portion that is very involved in this communication that encourages appetite and eating. And therefore, when we talk about the sleeve gastrectomy, we're not talking about a procedure that is purely mechanical and that is geared to just make the stomach smaller, but we talk about a procedure which is metabolic because it interferes with the various processes through which our body decides what's the right weight for us, because that's the crux of the problem, isn't it? At the end of the day, Kemal, is that if the body decides that the weight of the person should be much higher than whatever the person does to try to lose weight, they cannot really lose weight because the body defends that weight staunchly. And one of the ways in which it does that is through these communications that exist between the digestive tract and the brain. And when we do this surgery, we interfere with that communication and we reverse that set point to make the body think that a lower weight is actually acceptable for that person. And that's why weight loss happens so much more seamlessly with weight loss surgery as opposed to diet and exercise, for instance.
Absolutely. Now, one of the, I think the selection process is, I know that we look at patients' ages. If they're on a younger side, the sleeve is always a better option. And I don't know if you were going to go to the bypass from here, but I don't want to make that premature if that's not the case. So, but for the first option, I guess the sleeve is the go-to procedure. Now, let me actually maybe change the question a little bit differently, and then you can go to the bariatric in your own terms, or to the bypass in your own terms. So if someone comes to me with who had a band surgery already and then they didn't lose weight, or they did, but then it's back at the BMI 35, 36, and then now they're not happy with the band and thinking that they were having some issues, and now they want to have another band. And the patient is less than 65, over 60. What would be our course of action in the case of that?
So to begin with, the gastric band is actually the weaker of the procedures when you look at its power to induce weight loss. Like when you compare it to the gastric sleeve or the gastric bypass, you can see that the gastric band is not as powerful to begin with. So the chances of the person not reaching their goal weight is higher when they have the gastric band. The other issue that we see, as you know, of course, is that there are problems sometimes related to the device itself, because the gastric band is an actual device that is placed around the upper portion of the stomach. And often there are problems in terms of being able to swallow, nausea, vomiting, and therefore that can be so recurrent that the person may have the gastric band removed for that reason. And if they're still struggling with the weight, obviously the question is going to be what next? Well, it makes not much sense to retry a procedure that hasn't worked to begin with, Kemal, right? And also, when we do procedures the second time round, we call them revision surgeries, the body is actually much more entrenched in its response. So weight loss is actually harder when you do the procedure the second time round, right? So when you're doing it for the second time, to go still with a weaker procedure again doesn't make sense. But as I said at the beginning, Kemal, the decision on whether to choose one surgery versus the other is a collaborative decision, which means the input of the surgeon as well as the patient are important. So if the patient from their comfort level feel that only the band is something that they will go with, unless there are other contraindications, the band is actually obviously better than doing nothing, as we know. But as you correctly said, if a person has tried the band before, you would want to go with a more stronger procedure like the gastric sleeve or the gastric bypass as your next option.
So now if we were to go to the bypass, what would be the process for those, and where you would feel like bypass would be the right choice for the patient?
Yeah. So gastric bypass has been for many years the golden standard of bariatric surgery. And the reason for that is because it is really the very first well-established procedure that bariatric surgeons have had. The gastric sleeve is something that has been popularized in the last 10, 12 years mainly. Now, it makes really a lot of sense why a lot of people choose gastric sleeve as their first procedure, right? Because with the gastric sleeve, all we are doing is removing a portion of the stomach. Importantly, we are not doing anything to the small intestine. We're not cutting the intestine. We're not rerouting the intestine, very important. Now, rerouting the intestine is something we do with the gastric bypass. So intuitively, most people who are looking at bariatric surgery will come up and ask for the gastric sleeve. And in the vast majority of cases, the gastric sleeve will be absolutely appropriate, and it will be a powerful enough procedure to serve them. There are some small instances, for instance, where we say the sleeve is not a good idea. Let's go to gastric bypass. For instance, a person who has developed severe irritation of their food pipe, something called Barrett's disease, for instance, we would say maybe going to gastric bypass is better. And the reason we say that is because with gastric bypass, we're able to isolate the food pipe from the acid of the stomach. But we are rerouting the intestine. Now, rerouting the intestine has its advantages, but also its drawbacks. The advantages of rerouting the intestine with gastric bypass, as I said, you're avoiding this acid irritation of the food pipe. And then also, there is actually an advantage in getting a procedure which is more powerful in tackling type 2 diabetes, and we've seen that as well, right? But what are the drawbacks of gastric bypass compared to the sleeve? Well, when you're rerouting the intestine, you're interfering with the person's ability to absorb vitamins and other essential micronutrients. So danger of vitamin insufficiency is there. But also, Kemal, when you cut the intestine and you put it in an unnatural position, which is what surgery does, you are actually putting the intestine at risk of being twisted and cause bowel obstruction, which sometimes can be a very, very serious or even life-threatening condition that requires surgical approach. So if you don't have to reroute the intestine, obviously it's not necessary. Another thing that we talk about, obviously, in terms of risk of gastric bypass is formation of ulcers, and ulcers can bleed, they can perforate, and all that is avoided when you're doing the sleeve. Now, as I said, there are certain situations where the gastric bypass is the chosen procedure, but the vast majority of patients will be absolutely fine with the gastric sleeve.
So the term bypass, and then you mentioned the vitamin deficiencies. So when we don't have a stomach anymore, right? So in the situation of the bypass, the stomach is not doing what it should be doing because there's no stomach. Is that right?
Well, a little bit more correct, yeah.
It's not connected to the food pipe.
Correct. So the food is not being routed through that early portion of the intestine, which just follows the stomach. It's called the duodenum and the early jejunum. And that is the most powerful portion of our intestinal tract in terms of absorbing certain vitamins and nutrients. And so if the food is not passing through that, well, absorption may not occur for those important vitamins. Yeah.
So now, for those who may be in the middle of making this decision, one of the things that we do is an EGD and endoscopy, upper endoscopy, and if someone decided to go with gastric sleeve, but then we find out that they have Barrett, there are a couple of ways that we kind of go by. Either patient doesn't have any problems with going with bypass, or if they have any doubt, or if there are any clinical other conditions, that we may actually repeat the EGD second time to validate the first one. In some cases, I know that patients do come back with questions like why they have to go through this. So when you say Barrett, I know what it is in terms of what we need to do and what we don't need to do. But for those who don't know what it is, if you can just explain that so that those patients can benefit from.
Yeah, absolutely. So Barrett's disease describes essentially a condition in the lower end of the food pipe, that end of the food pipe that immediately connects with the stomach. And in that is a condition that develops after there has been irritation of the food pipe over a long period of time with acid. Now, the potential risk of Barrett's disease is that tissue, that lining could sometimes, in a small fraction of people, that can change itself into cancer, right? So cancer of the food pipe could potentially develop in some fraction of people who have Barrett's disease. Now, if that is the case, it is important to minimize ongoing irritation of that area with acid. Well, you cannot avoid that with the sleeve, because the sleeve has the stomach still connected to the food pipe, and acid will continue to bath that area. So theoretically, we want to avoid that. So if we discover Barrett's, we say, look, probably the better option for us in terms of achieving weight loss would be to go to gastric bypass, although gastric bypass has its own drawbacks, because in this particular situation, we want to minimize the risk of potential evolution of Barrett's disease in something more sinister like cancer, essentially. Now, all these are theoretical considerations, of course, and there are maybe other considerations also to say that, if a person were to develop, cancer of the lower end of the food pipe, then having an intact stomach is important for the future surgery and so forth. These are all theoretical considerations, but still valid. But at the end of the day, Kemal, it is very important to understand that the most critical discussion is the one that occurs between the surgeon and the patient at the time of consultation. And why is that? And it is because everyone is different. Everyone is different in terms of their actual medical condition. So yes, patients will be likely to have Googled and come up with some conclusions about what may something mean or not, but Google does not write about that individual patient, right? Google writes generalized information, which often may not be accurate as well, right? Or may not be applicable to a particular situation. So that is why you and I have these informative discussions on our Bariatric Friday, but ultimately our patients are going to decide on their treatment course after they come to our practice for a consultation, where we have extensive discussions after review of their medical condition. And that discussion is actually ongoing. As you know, our patients have to go through a fairly extensive process of evaluation with nutritionists, with psychologists, and other specialists, and they will be meeting up with their surgeon on a number of occasions through that process. And those occasions will be important for them to continue that discussion so that they feel comfortable with the choice they make about what is ultimately better for them.
Well, we don't Google anymore, Dr. We do ChatGPT. So a little bit more advanced now, a little more sophisticated, but still not as good as the initial consult that they would have with a surgeon. Now,
I bet if I say ChatGPT instead of Google, many people may not know that yet.
They probably do.
Google has pervaded our language so much now to replace research.
Now we upgraded. So now, dealing with patients, communicating with patients on a daily basis, I know that not everyone is able to make this decision on their own, but then there are way too much out there where it kind of probably influence the patients in a wrong way in terms of what's right and what's wrong with them. Do you find patients coming to the office for the first consult, like kind of like opinionated? So they already know that this is what they are going to do in terms, even if you told them, no, this is not the right thing for you. Or is it like that?
Naturally. So, because first of all, this is a decision that evolves over time, right? They think about it maybe even as long as 2-3 years prior to actually taking action and coming to the office. So through that time, they will have had experience and interactions with people who may have had the surgery before, and they may have seen results that may have been appealing to them or not. So they will form an opinion as to what they want. And as I said, in the vast majority of cases, actually, we are able to accommodate what patients are comfortable with, right? But it is important, of course, for us to go with them through their individual history and then counsel them at what might be best. I can tell you, and you probably have the numbers as well, the vast majority of patients are undergoing sleeve gastrectomy. And this is not just particular in our practice, it's actually nationwide. You can see that the levels of sleeve gastrectomy are much, much higher, right?
It's about 75% overall, and a little bit more for us with the surgery center. So,
so the sleeve gastrectomy,
less complicated, and if they don't have those comorbidities, it's kind of the right way to go. But I was just thinking, because I used to have maybe less interactions with the patients in the last, in the last 3-4 years. I do have more. Because now with the case conferences and having those on a daily basis, so I end up just calling the patient. In some cases, I have like 7-8 other people, but I do pick and choose who to call based on the difficulties they may have. And, patients are pretty opinionated when it comes to what they want. So I was just kind of wondering how open they are to take the recommendation directly if they already make their decision and they don't want to go back.
And after the discussion, we're okay to follow what the patient is comfortable with, as long as there are no major contraindications to do that. As I say, I presented the issue of the Barrett's, for instance, which is an important one, but there may be other considerations as well, which may make a patient really go with one procedure versus the other. So we've talked about the sleeve, where we are removing just the stomach, and then that is really the procedure. And then gastric bypass, where not only we cut the stomach, but we reroute the intestine as well. But both procedures are done laparoscopically, which means we make very small incisions. And in our program, in the vast majority of cases, this is an outpatient procedure, which means patients go home the same day and recover fairly quickly from these procedures as well. Of course, they are surgical procedures. Go ahead.
I was just going to you kind of stole my line on that, because I was just going to talk about how actually straightforward to take care of these patients after the surgery. And we send them home 99.9% of the time. After the operation, it's about 6 hours average that they stay in the surgery center. Yet, how much they have to go through to get the surgery done, and then also that fear. Like if you were to just ask any random person their opinion of how risky bariatric surgery versus a gallbladder, they're going to say, well, bariatric probably is like 10 times more riskier. In fact, that's not the case. Maybe they're even they're maybe same, or maybe bariatric surgery, I would say less, because in many cases, most cases, it's not happening because of the emergency. So we prep the patient for 3 to 6 months. We get all the clearances. So, but yet, patient is discharged same day. So many people, and it's kind of new because the other day I was looking at one of the marketing materials from one of the hospitals. the way they are emphasizing like the hospital side of it, but we don't want our patients to go to the hospital. This is not a hospital procedure. If it can be done with the team that's specialized in bariatric, this is our boutique. Like no one does this better than we do in anywhere else, like hospital or not hospital. So, and if it can be done in the outpatient setting, and if you can go home on the same day, it tells you one, it's not too complicated, or is the perception of the complication is not right. And the other thing is, well, you'll go home. So there's no hospital fear of staying in the hospital or getting staph infection at the hospital, and all those issues that you have complications. So this is the best place to do it, and same day home. So I think that says a lot for those who really want to follow what we are saying. So this is not a procedure where you have to stay in the hospital for a week. So and then that's what we are prepping the patients for, the clearing process, getting them ready with several different specialties, multidisciplinary approach. And I'm glad that we are able to help those individuals who are choosing the program.
Absolutely. So, as you correctly say, the reason patients are able to go home so swiftly after surgery is because of that extensive preparation beforehand. So that extensive preparation that we put in at the beginning is really to get the patients ready medically, mentally, and in every other way, so that their surgery goes smoothly, their recovery goes smoothly, and they are well prepared, even mentally, to recover very, very quickly. As you mentioned, the vast majority of patients do very well in this setting. Of course, there are patients that would not be appropriate candidates for outpatient surgery, and they have to be done in the hospital. There is no question about that. But the vast majority of patients will be able to be done in an outpatient setting. And then, as you said, there is no exposure to other illnesses that may be circulating in the hospital. And as you said, there is this important component of comfort that patients will experience when they go and have a procedure in a center that specializes in that procedure, where, from the person who greets them at the door of the surgery center to the nurse that helps them get discharged, all they do is bariatric surgery day in and day out. So that level of care, obviously, when it can happen, and in our setting, obviously, it is happening, it will be desired. Who would be against that? There is no question about that, right? But obviously, there are patients who may not qualify for that because they may require higher level of care if they have severe heart disease, severe kidney disease, severe lung disease. In that case, a hospital setting would be appropriate. And obviously, our surgeons are able to work in hospitals. As you know, CHRIAS surgeons have been instrumental in actually building up the bariatric programs in our area, whether it's St. Francis Hospital, Christiana Hospital, Bay Health. Many of the surgeons who work in these places were actually trainees under the CHRIAS surgeons who really have started bariatric surgery in our area about 20 years ago.
We were hoping that this would help those patients who are in the middle of making the decision to decide which surgery type would be right for them. And we'll be back with another topic next week. Until then, try to stay cool. The weather situation is really bad, especially for, I believe, for those patients with the who are struggling with morbid obesity. Probably it's a bigger problem. So try to stay indoors as much as possible, places with ACs. And if there isn't enough, then go to the mall. Just don't do any food shopping there. And we'll be back next week. Thank you for watching us.
Good advice. All right. Bye-bye.